Good evening, everyone. Is audio video clear? Good evening, everyone. Is audio video clear? Okay, let's start it. We will be starting with uterus prolapse. Okay, so basically, when the cervix, when the uterus comes down, it is known as uterus prolapse. When the uterus comes down, uh, the normal position of the cervix is at the level of ischial spine. When the uterus comes down from the ischial spine into the vagina or later, then it is known as supports of uterus prolapse. Uterus is maintained there due to the supports of uterus. The supports which are the main supports are known as primary supports. The supports which are of lesser which are giving less support are the secondary support, and no support are those which don't support at all. Okay, no support are those which does not support at all. Okay, so the primary support mainly consists of the muscular support, or the one which is making the pelvis floor, the one which is making the pelvis floor. We have studied the pelvis in the labor, right? So those, the pelvis is the pelvis floor is made by the levator ani. So levator ani muscle is the main muscle which supports the uterus. Okay, levator ani is the main muscle which supports the uterus. Okay, as you can see in this diagram, that this is the levator ani. Okay, this muscle is the levator ani. All of you please focus in the camera. All of you please focus in the camera. See, if this is uterus, then levator ani is holding the uterus like this. Okay, if this my pen is uterus, then levator ani is holding the uterus like this, and it also making the pelvis, which we studied in the obstetrics. The levator ani is also making the floor of the pelvis. Okay, so this is the levator ani muscle. It is totally covering the outlet of the pelvis, right? So which is the main support of the pelvis? The main support of the pelvis is levator ani. Okay, so most of you mark in the MCQs ligaments. Ligaments are not the main support. Levator ani is made up of three muscles. Okay, three muscles. As you all know, the pelvis is made up of three bones. What are those bones? Pubis, ischium and ilium, right? The pubis, the muscle fiber from the pubis goes to the coccyx in the behind, and the parts are pubococcygeus, pubococcygeus pubococcygeus and number 2 is ischiococcygeus. Yes, sorry, it is ilio, not ischio, it is ilio. Okay, the three muscles, as levator ani is very important, either in the anatomy or either in the gynae, they can ask you levator ani is made up of which muscle? Pubococcygeus, ठीक है, Iliococcygeus, and number 3 is puborectalis, from the pubis to the rectum. Okay, so which is the main support of the uterus? It is levator ani, right? Or the pelvic floor or the pelvic diaphragm. They quite often confuse you people in by giving different names. So these are one and the same thing: pelvic floor, pelvic diaphragm, or levator ani. Now, out of these three muscles, which muscle is injured in episiotomy? Out of these muscle, which muscle is injured in episiotomy? The muscle which is injured is pubococcygeus. Because what do we doing in the episiotomy? What are we doing in the episiotomy? We are making a cut from the posterior wall of the vagina to the towards the anus. Hello, Dr. Kavita. Okay, what are we doing? So we are mainly cutting. Yes, we are mainly cutting which muscle? The one which is posteriorly. So which is posteriorly? Which is posteriorly, beta? Pubococcygeus. See, coccyx is the most posterior part, right? Pubococcygeus. Okay, and now tell me which muscle when it weaks down causes prolapse? Prolapse is mainly anteriorly. Okay, so puborectalis. If puborectalis is not in the option, then you will take pubococcygeus. Okay, so first of all, this is something new for you all. Levator ani is made up of three muscles: puborectalis, pubococcygeus, and iliococcygeus. Iliococcygeus. Dr. Isra, please correct in the chat box. Yes. So which is the muscle which is injured in episiotomy? In the episiotomy, pubococcygeus, because it is posteriorly. And which is the muscle which when weak leads to prolapse? Puborectalis. If it is not in the option, then of course pubococcygeus. Okay. Okay. So the main support is by the pelvic floor, right? The main support is by the pelvic floor. Now we will study the second primary support. The second primary support is by the uterine axis. If the uterine axis would have been straight, if it would have been straight, the uterus would have fall down. You would have come down due to gravity. Okay, uterus would have come down due to gravity. Okay, uterus is not coming. It means that it is a curved angle. Okay, so the angle between the uterine axis and the cervical axis is known as which angle? Anti-flexion angle. So this is last year NEET PG question, and last three year PYQ, that which ligament is maintaining anti-flexion? Which ligament is maintaining anti-flexion? It is the round ligament. Okay, it is the round ligament. Okay, anteversion means the angle between the cervix and the vagina. V for version. V for vagina. The angle between the cervix is common to both. Okay. So, which are the two ligaments they give in combination? Main support is by the uterosacral. Very good, Dr. Kavita. Dr. Isra, very good. Which are the two ligaments maintaining the uterine axis? Write down in the chat box. This is previous year NEET PG PYQ. High chances it will come to you people also. Yes. Anteversion is maintained by uterosacral and round ligament. If they give you one choice, then the answer will be uterosacral. If they give you one choice, the answer will be uterosacral. Okay, now after uterine axis, third is the you are not going to write pubocervical beta. Answer is answer is round ligament. Okay, Dr. Isra, uterosacral and round ligament. It is not pubocervical. Okay, please correct it. It is not pubocervical ligament. It is round ligament. Yeah, very good. The ligament support. Let us study the ligament support. Ligament support is by which ligament? Three ligaments, and they go radially. Okay, the three ligaments, they go radially. The three ligaments, they go radially. That is why it is known as triradiate ligament. Triradiate ligament. They go radially. And what is the center point? Cervix. From the cervix, they are going radially. The one which is going transverse is McEnroe ligament or cardinal ligament or transcervical ligament. Is it okay? Is it okay? Okay. Very good. And the ligament which is going interiorly from the cervix, it is going interiorly, is the pubocervical ligament. And the ligament which is going from the cervix to posteriorly is the, very good bacha, uterosacral ligament. Okay. So these three ligaments, they start from the cervix and they go transverse is transcervical. The one which go posteriorly is the uterosacral. The one which goes interiorly is the pubocervical. Okay. So you have to remember that the main ligament of this triradiate ligament is the McEnroe ligament. Okay. McEnroe ligament. It is the main ligament. Okay. Is it okay? Okay. Now what is the secondary support, beta? Secondary support, not the main support, is the round ligament. And the ligament which gives no support is Dr. Isra, Dr. Kavita, all those who are attending, please. The ligament which gives no support is the broad ligament. Okay. Okay. Now when uterus prolapse, not only the uterus prolapse, uterus comes down from its position. What else comes down? What else come down? Vaginal wall also come down. Okay. Okay. Vaginal wall also come down. Good evening, Dr. Jessica. Vaginal wall also come down. Okay. Very good. When anterior vaginal wall come down, it is? Yes. When the anterior vaginal wall come down, it is? Tell me. When the anterior vaginal wall come down, it is cystocele. And it is in the upper 2/3. Okay. Upper 2/3. You have to remember that upper 2/3 when comes down, it is cystocele. In the rectocele, what part comes down? Posterior vaginal wall. And what part of the posterior vagina? Lower 2/3. Okay, these are some basics which can be asked in FNG, that which in the rectocele, posterior vaginal wall comes down or gets prolapsed, but which part? Lower 2/3. In the cystocele, upper 2/3. Shaw's has given a classification for the uterus prolapse. What is the Shaw's classification for uterus prolapse? So we know that in prolapse, uterus comes down. Okay, uterus comes down in the prolapse. So if this cervix is above the introitius, it is first degree. So we have to see where the cervix is in relation to the introitius. Okay, where the cervix is in relation to the introitius. What is introitius? The opening of the vagina. If it is, very good, Dr. R.P. Soni, if it is above the introitius, it is first degree. And if it is at the cervix has come down and it is at the level of the introitius, it is second degree. And if the cervix has come out of the introitius, that is, it is down the introitius, it is third degree. Okay, is it okay? Understood? Okay. Now, as you see that in the Shaw's classification, we were not able to know that the uterus, we know that uterus has come down, but we were not able to measure how much was the cystocele, how much was the rectocele. We were not able to measure it. Okay. We were not able to measure how much was the cystocele, how much was the rectocele. So, the internationally accepted classification is the POPQ classification. What does the P stands for? POP. What does the POP stand for? Pelvic organ prolapse. And Q stands for quantification. And Q stands for quantification. Okay. Okay. Good evening, Dr. Abdul Hasif. Q stands for quantification. Is it okay? Basically, there are 9 points in it. How many points are there in it? There are 9 points in it. Okay? There are basically 9 points where we measure how much is cystocele, how much is rectocele. So, we have to remember only 2 things about this classification. What are those 2 things? Number 1, there are 9 points. And what is the reference point we take? Hymen. What are the reference point we take? Reference point is taken as hymen. Okay? Hymen is taken as the reference point. Okay? Is it okay, everyone? Very good. Now is the main part. What are the surgeries done? This is very frequently asked. Dr. Soni, do you want to ask anything? Very good. So now let us see that what are the surgeries done for the prolapse. First of all, surgeries depends on 2 things. Depends on 2 things. What are they? The age and the parity. Age and the parity. You all know if we remove the uterus, then what will happen? If we remove the uterus, then patient will go into menopause. Right? So we have to do it according to the age and according to the parity. If the patient wants the uterus or not. Is it okay? Now, if the patient's family is not completed, that is, patient wants bacha, patient wants to get one more child or wants child from the uterus, then we cannot touch the uterus. What is the surgery we do for it? We do sling surgeries. We do sling surgery. What are the famous sling surgeries? The common sling surgery which we are doing now, they are the Shirodkar, very good, Shirodkar and Pudendre. Shirodkar sling surgery or Pudendre. Okay. Examiner sometimes get very smart, does not write in the last link. Okay, examiner sometimes get very smart and does not write sling in the last. Okay, so you have to learn the name also. What are the surgeries done for the woman who wants child? It is Schrodker or Pudendre. Okay, very good, Dr. Jessica. There is a quite long lag. Okay, that is why I am not asking you questions. Okay, Schrodker or Pudendre. Now, for a lady like me, okay, who has completed the family, for a lady who has completed the family but less than 40 years, so the lady will not want her uterus to be removed. Okay, no, Dr. Abdul, it is not pelvic floor repair, it is only sling surgery. Okay, it is only sling surgery. Okay, okay. So if the family has not completed and the age is less than 40 years, then the surgery which we do is Manchester or Fothergill. Manchester or Fothergill. What we do in the Manchester and Fothergill? Can anybody tell me? We do cervical amputation. We do cervix amputation. We cut the cervix. Okay? We cut the cervix. How you will remember? Manchester and Fothergill. They have completed their family. So, वो mother father बन गए. They have become mother father. Okay, so they have become mother father of the children, of all the children they want to become. Okay, so you will remember M for Manchester and F for Fothergill. Mother father. Completed family means they have completed their mother father. Okay, cervix amputation. We do the cervix amputation. Okay, clear? Okay. Now for the female who is completed the family and is more than 40 years, what is the surgery we do? The female who has completed family and who is more than 40 years. So now female is going into the menopausal stage already, right? So what is the surgery we will do? We will do vaginal hysterectomy. Why don't we do abdominal hysterectomy? Can anybody tell me? Why don't we do abdominal hysterectomy? Anybody can tell me? Okay, because we have also to cure the hysterectomy will cure the uterus prolapse, but we have also to cure the vaginal prolapse. So what are the surgery we do for vaginal prolapse? For the interior vaginal prolapse, we will do anterior colpo. Colpo means, very good. Colpo means vagina, and next is raphe. Raphe means repair. Okay. Anterior colpo raphe. Colpo means vagina. Raphe means repair. So anterior vaginal wall repair is done by anterior colpo raphe. Posterior vaginal wall repair is done by posterior colpo perineo. Answer is perineo raphe. Is it okay? Posterior colpo perineo raphe. And what is this whole surgery known as? Dr. Kavita has already helped us. Ward Mayo. How you will remember it is Ward Mayo? Can anybody tell me how you will remember it is Ward Mayo? Vridd Ma. Completed family and more than 40 years. Vridd Ma. Vridd is for old age and Ma is for mother. So Vrit Ma. Okay. So that is how mainly these three things will be asked. If family is not completed, then there will be sling surgery, Shirotker sling surgery, or Pudendre sling surgery. If family is completed and age is less than 40 years, then Manchester or Fothergill. And if the family is completed and age is more than 40 years, then Ward Mayo. Okay. Now, you all will tell me what are the surgery we do for cystocele? What is the surgery we do for cystocele? Some more surgery names. What are the surgery we do for cystocele? Yes. What are the surgery we do for cystocele? Anterior colporaphy. Okay, they can ask you like this also. What is the surgery we do for rectocele? Posterior colporaphy. Not only posterior colporaphy, it is posterior colpoperineuropathy. Okay, very good. And what is the surgery we do for vault prolapse? What is vault basically? What is vault basically? Surgery we do for cystocele? What is basically vault? We have the part of the vagina which is left after removing the uterus. We stitch that. Okay. For example, if this is uterus and we have removed this uterus, right? And we have removed this uterus by doing vaginal hysterectomy. We have removed this uterus, right? So, and then what we do? We stitch the upper end of the vagina like this. Okay. So, this is this part, this upper part which we have stitched is known as the vault. Now, this vault also prolapse. This vault also prolapse. Now, what is the surgery we do for vault? We fix this vault. Posteriorly lies the posteriorly lies which posteriorly lies which bone in the pelvis? Posteriorly lies which bone? Sacrum. So we fix this vault with the sacrum and it is known as sacrospinous sacrocolpopexy. Very good. It is sacrocolpopexy. We can also fix it to the uterosacral or sacrospinal ligament. We can also fix it to uterosacral ligament or uterosacral or sacrospinal ligament. Okay, so every vault surgery will have what in common? It will have sacrum word in common. It will have sacrum word in common. Okay, it will have sacrum word in common. Okay, is it okay? Okay, so you have to remember that sacrospine colpopexy, any surgery with sacrum name in there will be for the vault prolapse, uterosacral ligament, sacrospinous fixation. Okay, very good, very good. Okay, now the enterocele. What are the surgery for enterocele? Can anybody tell me? What are the surgery for enterocele? What are the surgery for enterocele? The most common surgery which we do today is yes, the most common surgery which we do today is McCall surgeries for enterocele. It is McCall Caldoplasty. Okay, this is the most new surgery. Okay, this is the most new surgery, and mostly it is done this. Okay, the old surgery is Halbane's and Moshowitz. Okay, Halbane or Moshowitz, right? Halbins or Moshowitz. Very good. So the surgery which we do for enterocele is Halbin or Moshowitz, and the most new surgery is McCall. Okay. So we have completed all the surgeries. The one surgery which is known as obliterative surgery. What we do in the obliterative surgery? What we do in the obliterative surgery? We basically fuse the anterior wall with the posterior wall of the vagina. Okay, and this is known as obliterative surgery. We fuse the anterior wall and the posterior wall of the vagina. It is done in which patients? Can you tell me? It is done in which patients? Those patients which have very high morbid diseases, that we cannot anesthetize those patients for 1 hour or long. Okay, so in which patients the Lee forte colpoclysis is done? Lee forte colpoclysis is done beta in those patients in which, because the patient they have very high morbid diseases like MI, diabetes mellitus and hypertension. So we cannot anesthetize these patients for the extensive hysterectomy surgeries. So we do Lee forte colpoclysis. How you will remember Lee forte? How you will remember beta? Ki Lee forte is for the patients. Very good. Because we will tell the anesthetist. What we will tell the anesthetist? You are not allowing us to do the surgery. ले फिर हमने colpoclysis कर ली. Okay? Colpoclysis कर ली. Right? Is it okay? Now let us discuss the etiology of prolapse. What is the main support of the prolapse? What is the main support of the prolapse? Levator ani. So the etiology will always go near the levator ani. Okay? The etiology will always move near the levator ani. Anything which weaks the levator ani will prone the patient to prolapse. What weaks the patient levator ani? Tell me. what weaks the patient levator and I? Pregnancy. Because I already told you, यूट्रस को एकदम गोदी में उठाया हुआ है. The uterus is in the lap of the levator and I. Right? I already told you, if this my pen is, if you are not able to see, if this pen is levator, if this pen is uterus, then levator and I is like this, holding it like this. See, like this. So if any pregnancy will occur, it will surely weak the levator and I. Okay. If the patient goes through labor pains instead of going for cesarean, then again the levator and I will weaken. Okay. Because this muscle levator and I also has estrogen tone other than neural tone. This muscle also has estrogen tone. So as the menopause occurs, the levator and I weakens. Is it okay? Levator and I weakens. So the main three reasons for the prolapse is, more are the pregnancies, more the prolapse occur. More the patient suffers labor pain, more the prolapse occur. The patient when goes into the menopause, again the prolapse occur. All the procedures which cut short the second stage or which cut short the labor, which will prevent the prolapse. So what are the surgeries which prevent the prolapse? What are the surgery which prevents the prolapse? Yes, forceps application, vacuum application, episiotomy, doing cesarean instead of doing labor or pains, doing cesarean. So they can ask in the exam, the patient who has gone through cesarean and the patient who has gone through normal vaginal delivery, which has high risk of prolapse. So you are going to write down in the chat box this. A patient who has gone through cesarean and patient who has delivered the children normal, which will suffer prolapse. Okay, I will give you answer if you will write in the chat box. Now let us study the, yes, urinary incontinence. Okay, very superficial view we will want for urinary incontinence. First of all, what do you mean by incontinence? What do you mean by incontinence? Incontinence means that urine is coming at inappropriate time. Okay, most of us think that urine is leaking through vagina is incontinence. No, big no. The urine, if is coming at inappropriate time, we have normal control on urine, right? We want to pass urine or micturate only in the loo. If the urine is coming at inappropriate time, then it is incontinence. If the urine is coming through fistula, beta, then what is it? If the urine is coming through fistula, it is, if the urine is coming through vagina, it is, yes, very good, Dr. Isra, it is Ritchen maneuver, very good. If the urine is coming through vagina, it is fistula. Okay, so you should know what is incontinence. Incontinence means urine is coming at inappropriate time. Okay, urine is coming at inappropriate time. It doesn't mean, very good, Dr. Jessica. What is stress urinary incontinence? That urine is coming when there is increase in stress. Okay, urine is coming out when there is increase in stress. It is not related with mental stress, beta. It is related with, yeah, the answer to this question is the patient who has undergone normal vaginal delivery will have more chances of prolapse. Okay, then cesarean. Very good, very good. Okay, now what is stress urinary incontinence? That urine is coming out whenever there is increase in the stress. It is not related with mental stress, it is related with increase in the abdominal pressure, that is increased on coughing and laughing or while doing Valsalva maneuver. Okay, what is urge urinary incontinence? What is urge urinary incontinence? When a patient has the urge, then we can control normally our urine till we go to the loo. If the patient is not able to control the urine and with the urge the urine leaks out, then it is known as urge urinary incontinence. That as the urge comes, the urine get leaks. Okay, mainly questions comes on stress urinary incontinence, so we will discuss it that only. Okay, very good. Stress urinary incontinence is, yes, why it is there? What is the etiology behind stress urinary incontinence? The intrinsic sphincter weakens. Okay, the intrinsic sphincters weakens. Okay, intrinsic sphincter weakens. What is intrinsic sphincter? It is nothing but levator ani. It is nothing but levator ani. So what are the factors which weakens the levator ani? We have already discussed. What are the factors? We have discussed it is pregnancy, it is labor pains, it is menopause, right? It is pregnancy, labor pains and menopause. Okay, what are the other factors which weakens the levator ani or the intrinsic sphincter? It is obesity. That is why we studied the factors late. Obesity or the females who are doing weightlifting very vigorously. Okay, the weightlifters, that weakens the levator ani. Okay, is it okay? Okay, now this question can be asked that most common incontinence in young. What is the most common incontinence in young female? It is stress urinary incontinence. Okay, because most of the females who are obese, they undergo to this. Okay, 50% of the females are obese. 50% of females, either they are obese or they are weightlifters. All this labor are very good, Dr. Kavita. It is right, due to anterior colporrhaphy. Very good. Okay, so either the females which are of the BPL are labor class, right? They are doing labor daily, so they are weightlifters. Okay, so this question can be asked, most common one incontinence in young women. It is, yes, write down in the chat box. It is stress urinary incontinence. And what are the investigations? What are the tests which we do? Stress test. What are the stress tests? Yes, we make the patient to lie down in the lithotomy position and we tell the patient to increase the abdominal pressure. Okay, so that is known as to ask the patient to cough or laugh. Okay, so if the patient urine comes out, then it is the stress test positive. What is Q-tip test? on a stick we put the swab, okay, and then we keep that swab stick into the urethra, and if that urethra if with increasing the abdominal pressure if the stick moves, then it is known as positive. And what is Marshall Bony test? With the help of the two fingers we support the internal sphincter, okay, and if now after supporting the internal sphincter the urine does not leak, it means that it is due to the stress urinary incontinence. So these are the three tests for stress urinary incontinence. What are the three tests for stress urinary incontinence? The three tests are stress test, Q-tip test and Marshall Bony test. What is the treatment? Yes, conservative treatment is pelvic or Kegels exercise to strengthen the pelvic floor, to strengthen the levator ani. Okay. And what are the drugs? The levator ani has got weak. The supply of the levator ani is by the adrenergic, alpha adrenergic are supplying. Okay. You all have learned the physiology of micturition, isn't it? You all have learned, right? So the alpha adrenergic agonist we have to use. What are the name of alpha adrenergic agonist? Imipramine or ephedrine. What are the name of alpha adrenergic agonist? It is imipramine or ephedrine. Okay, it is imipramine or ephedrine. Other than imipramine, ephedrine, we can give SSRIs, that is duloxetine, or estrogen or estrogen. Okay. And what is the surgery? The gold standard surgery is Birch-Kolpo suspension. But the treatment of choice is transobturator tape or transvaginal tape. Okay. Okay. So if the word they have used the gold standard surgery, it is Birch-Kolpo suspension. And if they have asked the treatment of choice, then it is transobturator tape or transvaginal tape, because this is the OPD procedure. Because this is OPD procedure. Very good, Dr. Jessica. Because this is OPD procedure. Okay. Very good. Now what are fistulas? Fistulas are a communication between the two tracts. If the urine leaks through the vagina, then it is known as fistula. Okay. If the urine leaks through the vagina, then it is known as vesicovaginal fistula. Communication between the urinary tract and the genital tract. What is the most common cause of VVF in India? It is the obstructed labor. Okay. What is the most common cause of VVF in the whole? Yes. Yes. Dr. Isra, it is right. It is alpha 3. Okay. What is the most common cause of VVF? Beta, what is the most common cause of VVF in the whole world? The most common cause of VVF in the whole world is? Yes, come on, tell me. Very good, tell me. Post-gynae surgeries. Okay. Post-gynae surgeries. Okay. But if they will ask you, you have to tell only the India cause. Okay. If they haven't asked in the very good. If they haven't asked in the question India or world, You will always answer obstructed labor. Okay? Okay. Now, when do the patient present? Next important thing. In the last exam, they have asked you questions from VVF. This whole slide is very important. When do the patient present? Patient went into the obstructed labor. When will the patient present? Patient will present 7 to 10 days after the delivery. Patient will present 7 to 10 days after the delivery. Patient, it cannot be diagnosed. Okay? Okay. Now, how the patient will have, what will be the complaint of the patient? These 3 lines are very important. What will be the complaint of the patient? Because the communication is between the bladder and the vagina, so there will be continuous leaking and no normal voiding will be present. Okay? Because the communication is between the bladder and vagina, so there will be continuous leaking. So there will be continuous leaking and there will be no normal voiding. Okay? Okay? Is it okay? Okay. So this is very important. What will the patient give the history? There will be continuous leaking and no normal voiding. Okay? So if the patient says that there is occasional leaking, and if the patient says there is occasional leaking and normal voiding, then it is uretrovaginal. Very good, very good, very good. Then it is uretrovaginal fistula. If the patient says it is occasional leaking and normal voiding, it means that the bladder is intact. It means that the bladder is intact. The leaking is somewhere upper to the bladder. So it is known as uretrovaginal fistula. Okay? Okay? Okay. Now what is the investigation of choice? It is the 3 swab test. Okay? When very good, Dr. Kavita. What is the investigation of choice? Or the first investigation? It is the 3 swab test. And what is the best investigation? Best investigation is cystoscopy. Okay? It is the cystoscopy. Okay? Very good. When is the repair done? When is the repair done? The repair is done after 3 months of the delivery. The repair is done after 3 months of the delivery. What is the name of the surgery? The surgery name is Let's Go surgery. Okay? The catheter is left there for how many days? The catheter is left there for how many days? It is left for 7 to 14 days. If they have asked you one option, then you will say 14 days. But then you will answer 14 days. Okay? Then you will answer yes. Very good, very good. Then you will answer 14 days. If a patient has undergone VVF repair, then intercourse is to be avoided for 3 months. The patient who has undergone VVF repair, the intercourse will be avoided for 3 months. If the patient who has undergone VVF repair, the pregnancy will be avoided for 12 months. Okay? A lady who has conceived after VVF repair, the delivery will be done only by cesarean section, and that also classical. That also classical cesarean. Okay? Now let us study something about pessary. Let us study something about pessary. Okay? Tell me, when is pessary used? When is pessary used? Tell me. If we cannot do surgery, in any condition, if we cannot do surgery, then the if we cannot do surgery, then it means that it is conservative management. Patient is asking the conservative management. Okay? We cannot do surgery in pregnancy or postpartum. Okay? We cannot do surgery in pregnancy or postpartum. Okay? Or in emergency. Okay? Because this is not a life-threatening condition that we will do the surgery in the, yeah. So, okay. So we will do it in emergency. Is it okay? How to check the pessary? How to check the pessary? Write down in the chat box. By asking the patient to pass urine. See, we cannot measure the vagina size, the vagina width. We have to keep pessary by estimation. Pessary comes in different sizes. Okay? Pessary comes in different sizes. Right? So we will put a pessary by estimation. Okay? And then we will ask the patient to pass the urine. Okay? If the patient is able to pass the urine, it means that pessary is not obstructing urethra. We will ask the patient to cough or laugh. Okay? Or Valsalva maneuver. Okay? If the pessary is very small for the size of vagina, then it will fall off. Okay? And the third is, if the pessary is of the large size, then it will enlarge the size as compared to vagina, then it will cause pain. So we will ask the patient about the discomfort. We will ask the patient for the discomfort. Okay? What is the reason of decubitus ulcer? It is the last slide for today. What is the reason for the decubitus ulcer? Venous congestion. What do you mean by venous congestion? When uterus prolapse, then the veins also come down, and introitious is a very narrow opening. Introitious is very narrow opening. Introitious is a very narrow opening. Okay? So the veins, they get congested. The blood supply, it gets congested. Okay? So what is the treatment of it? What is the treatment of it? That we have to manually reposition it. We have to manually reposition it. And how we will maintain that reposition? With the help of packing or pessary. Okay? With the help of packing or pessary. That was all for today. Let us see the images concerned with this topic. Okay. Now write down in the chat box, what does this first image tells? What does this red colored area is? The red colored area is? Write down what does this second image spot diagnosis? What does the fistula number 1 is? These are the diagrams of fistula. In the last exam, fistula was we were asked to diagnose the fistula name. Okay, what is the fistula? First fistula. As you can see, the communication is between the uterus and bladder. So it is utrovesical. What is number 2? What is number 2? Number 2 is vesicovaginal. Number 3 is urethrovaginal. Number 4 is rectovaginal. You have to just to see what two tracks are communication, and you can write down. Identify this structure. Very good. Identify this third structure. Please write down in the chat box. You all are not writing. Please write down what is this third picture is. Pessary. What is this image? What is this surgery being done? Very good, very good, very good. Very good. All of the rest of you students, please write down what is this surgery. As you can see that here it is written obturator membrane. So a tape is going from obturator membrane to the uterus. So it is which surgery? TOT, trans obturator tape. Very good, very good. Okay, now let us do the questions. Prolapse uterus following childbirth should be repaired. You will write down in the chat box with the number. This surgery is done for stress urinary incontinence. Okay. Prolapse uterus following childbirth. Should be repaired immediately. Should not be repaired. Should be repaired 6 months after delivery, or should be repaired after 12 months of delivery. Now here are the expected questions. Okay. Question number second is antiversion of the uterus is due to. This is NEET PGPYQ and it is very expected. Answer is question number second is this. Question number third is McCall's caldoplasty is for. McCall caldoplasty is for. Okay. Number 4, treatment of third degree uterus prolapse and cystocele in 60 years old female. Treatment of third degree uterus prolapse and cystocele in a 60-year-old female. Options are Schrodker sling, Lee Forte, Manchester, Ward, Mayo. Question number 5 is, fifth is all are risk factor for pelvic organ prolapse except. Question number 6 is Lee Forte is done for. Lee Forte is done for. Lee Forte is done for. Women over 40 with completed families, young women with third and fourth degree prolapse, or elderly menopausal patient with advanced prolapse, or women under 40 desirous of retaining the menstrual function. Okay. Next is more strong support of the uterus. More strong support of the uterus. Question number 8 is 45 years female has uterovaginal prolapse. Procedure, what procedure will be done? Options are abdominal hysterectomy with Moshowitz, vaginal hysterectomy, interior posterior colporrhaphy with McCall caldoplasty, vaginal hysterectomy with sacrospinal colpoplexy, or vaginal hysterectomy with McCall caldoplasty. Okay. Question number 9 is all are true for 3 swab test. If there is middle swab is stained, then it is VVF. Lower swab is stained, then it is urethrovaginal. Middle swab is stained, then it is stress urinary incontinence. Or if the upper swab is stained wet, not stained wet, then it is uretrovaginal fistula. Okay. Next question is conservative treatment for pelvic organ prolapse. 11th number question is 32 years old lady with IUD passes urine after normal vaginal delivery, is passing urine from vagina. What is the diagnosis? Cause of decubitus ulcer. What is the cause of decubitus ulcer? Question number 13 is most common surgery with high risk of ureter injury. And which is the most common surgery which causes the ureter injury? These are two different questions. Okay. Next is lady who had VVF repair. Now the lady has conceived. The mode of delivery will be What will be the mode of delivery? Classical cesarean, lower segment cesarean, normal vaginal delivery, or what? Okay. Next question is, 22 years female has cervix outside the vagina and cystocele. Next step. That's all for today. Now let me tell you the answers. Prolapse uterus following childbirth. The answer is should be repaired 6 months after delivery. Why? Because prolapse is not an emergency. Because prolapse is not an emergency. Okay? Because prolapse is not an emergency. It is good to do after 6 months. It is good to do after 6 months. Not to do in the postpartum phase. Not in the postpartum phase. Question number 2. Answer is round ligament and uterosacral ligament. Round ligament and uterosacral ligament. Okay. Question number 3. McCall caldoplasty is for enterocele. McCall caldoplasty is for enterocele. 60 years old female, 3rd degree uterus prolapse, ward myo. What is ward myo? It is vaginal hysterectomy with pelvic floor repair. Okay. Now, all are risk factor for pelvic organ prolapse except answer is instrumental delivery, because instrumental delivery fastens the second stage. Okay. Lee Forte is done for elderly menopausal patient with advanced prolapse. Here, none of the patient has morbidity. None of the patient has morbidity. So we took the age criteria. Because here any of the patient didn't have morbidity, so we took the age criteria. Very good. Most strong support of the uterus. Answer is levator ani. Okay, levator ani. Very good. Next is "45 years female had prolapse. What will be the procedure done?" Answer is vaginal hysterectomy. It will not be abdominal hysterectomy. Dr. Isra has asked why not Lee Forte? Because no morbidities mentioned. Leaf forte is never a good choice, beta. Leaf forte is just a temporary measure. Okay? Leaf forte is never a good choice. Leaf forte is just a substitute for the main surgery. Okay. Next is, what is the procedure done? Vaginal hysterectomy will be done. Abdominal hysterectomy will not be done. And then it is anterior and posterior colporrhaphy and McCall coldoplasty. Why we will not do this one? Sacrospinal is not done because sacrospinal is for vault prolapse. Okay. Answer to question number 9 is middle swab for stress urinary incontinence. Okay. Why? Because what are the tests for stress urinary incontinence? The tests are, yes, tell me. Stress test. The tests are stress test. What are the other tests? Stress test, Burns-Marshall test, Q-tip test. Conservative management for pelvic organ prolapse. Answer is Passeri. I think this question is repeated. 32 years old lady with IUD. Answer is VVF. Because urine is coming from vagina. After delivery in India, if urine is coming from vagina, it is VVF. Cause of decubitus ulcer is venous congestion. Please don't mark in this question. Friction. Most of you mark friction. Most common surgery with high risk of is Verdheim's. Most common surgery with risk to ureter injury is Verdheim's. Why? Because Verdheim's is a very extensive surgery. Very extensive surgery. Most common surgery where ureter injury occurs most commonly is the abdominal hysterectomy. Please, this question में फर्क है. Okay, in दोनों questions में there is a difference. What is the difference? In the first they are written which is the surgery in which there is very high risk. I would like to tell you, if we do 100 Verdheim's, then in 50 Verdheim's there will be ureter injury. Okay. But Verdheim's are not done that frequent. Verdheim's is for CA cervix. Right? Stage 2A. Up till stage 2A. CA cervix. So, Verdheim's are not frequent. What are frequent? Abdominal hysterectomies are frequent. Abdominal hysterectomy is a very routine surgery in gynae centers. Okay? So, most common surgery where actually ureter injury occurs is abdominal hysterectomy. But if we do 100 abdominal hysterectomies, then only in 3 or 4 the ureter will get injured. Okay? So, you should know that most commonly the ureter is getting injury in abdominal hysterectomy, because abdominal hysterectomy is done quite frequently. Okay. The lady who had VVF repair has conceived. The answer is classical cesarean. Lower segment cesarean नहीं करेंगे इस lady में. ठीक है. Lower segment के पास bladder है, नहीं करेंगे. वहां पे we will not do. Last question of the day. 22 years old female present in emergency room with fully outside cervix, The answer is pessary. Because it is an emergency situation, we will not do hysterectomy. I am waiting for your queries. Please write down your queries. Class on menstruation will be tomorrow. Already it is very late. Please tell me if there is any queries. I am in hurry to finish the class. This is the list of 15 expected questions from Urogynecology. Either the same questions will. Yes, Dr. Rachna, this is the list of expected questions. Either the question will be there or options will be there. Some, but around this will be the question build up. Can I close the session? Can I close the session?